Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. So I recently went on a couple of the TRT forums on Facebook. These were like two of the biggest TRT forums that are out there, and so there's like thousands of guys on there. And I was a little bit surprised to see that there were three main issues that just kept coming up over and over and over again. One of them was there were guys like posting their estrogen numbers and then kind of having a little bit of a freak out about it and talking about the dose of the aromatase inhibitor, specifically anastrozole, that their doctor had put them on, and if they need to increase it, that sort of thing. The other thing I saw, which again kind of surprised me, was a whole bunch of posts on guys asking how they can lower their SHBG, which I'm not going to talk about those two right now. I probably need to do other videos about that, but you don't need to lower your SHBG. And the disappointing thing about it was that there were guys posting about the different things that their clinics were doing to help them lower their SHBG. Everything from like oxandrolone to taking boron and all this stuff. And there were even like guys who were owners and managers of TRT clinics chiming in on that stuff, and like giving medical advice that they're not qualified to give. But I'm not gonna go there today, at least on those two subjects. I'll probably do another talk on those at a later time. But the one that was also like really prominent was the hematocrit issue, and there were guys asking all sorts of hematocrit and thrombosis related questions about TRT. There were questions about like how often should I donate blood? What's a dangerous hematocrit? I've got surgery coming up. When do I need to stop my testosterone? Like all of these different questions related to clotting and thrombosis, and some iron related questions in there as well. So that's what I want to talk about today, because those misconceptions just won't seem to die. And unfortunately, these forums are. One of them was run by like a really well-known physician. It's visited by a number of really good doctors and other providers in the space that have answered all of these questions in YouTube videos, on multiple occasions, given really detailed explanations why guys don't need to worry about this. And it just doesn't seem to have any effect, because guys are still talking about it. And, unfortunately, there's all these bros on there who are giving unsolicited and often, in fact, mostly like grossly inaccurate and just wrong advice to these guys. So the real lesson here, guys, if you have questions about about any medical issue in general, and especially if you have an issue with TRT, and you want advice on your labs, you want advice on your protocol, don't go to Facebook for medical advice. I mean, I would think that it would be like intuitively obvious that you wouldn't want a bunch of random yahoos that you don't even know giving you medical advice. It was disappointing because I felt like 90% of the questions that these guys were posting, they should have been answered by their doctor already, like when they were consented to be put on testosterone in the first place. And maybe they were and they just forgot, or they just weren't paying attention. I know a lot of guys use underground gear and stuff, and so clearly they're not going to sit down with a knowledgeable physician who's going to answer all those questions for them. But they shouldn't be coming on Facebook to get these questions answered. They should be talking to their physicians about it. And that obviously doesn't apply just to TRT, but just general medical advice in general. It's probably a terrible idea to go to Facebook or any other online social media platform to get medical advice from the masses. I'm not going to repeat some of the craziness that I saw on there, but anyway, having said that, let's talk about this clotting issue and the erythrocytosis, and polycythemia is the other term for it that just keeps coming up. So generally, like, it depends on the lab that you go to, but a hemoglobin above about 18 and a hematocrit above about 52 is considered abnormal by most laboratories in terms of their reference range. Most of the clinics that I saw these guys talking about, they were making their guys donate as soon as their hematocrit hit 50, which is which is kind of ridiculous. It's not supported at all by the medical literature, and I'm going to show you that here in a second. But 52 can be considered up to 52 can be considered to be completely normal. If you look at what the Endocrine Society says, and I think the American Urological Association is in lockstep with them, that they say that if your hematocrit is 50 or above, that's a contraindication to even starting testosterone therapy. And then if it gets above 54%, that's an indication to discontinue therapy. Again, I don't agree with that, and I say that only based on the current evidence in the literature, which I'm going to review a little bit here for you. But those are the current guidelines, and so I don't blame clinics that stay within those guidelines, because we do live in a very litigious society, and God forbid if some guy gets a little dehydrated and happens to have a stroke, and he just happens to have a hematocrit of above 54. Well, some plaintiff's attorney is going to probably latch onto that and then try to blame the testosterone for it. So, despite the fact that the guy was 300 pounds, chain smoked and had cancer, you know what I mean? But they're going to zero in on that hematocrit. So, it's not unreasonable for a clinic to ask you to donate blood if you get above 54%. But this 50% threshold that I keep seeing over and over again, and that the local clinics here in town use, is it's actually kind of absurd. There's just no evidence whatsoever to support that, and not surprisingly, they end up crashing people's ferritins, and guys end up feeling terrible, and then they're iron deficient, and it takes months and months and months and months to try to get their ferritin back up again, occasionally. So anyway, so let's talk about the rates of erythrocytosis just real quick here. So this is a good chart that I think you might find useful. So as you guys are probably aware, like intramuscular testosterone is most likely to cause erythrocytosis. So if you look at like enanthate and cypionate, and you do it IM, and sub-Q is the same too, but you're looking at like roughly 2/3 of guys will have a significant bump in their hematocrit. Doesn't mean it's going to go above 54, but a rise like greater than 5% is super common. So like up to 2/3 of guys. And again, this is a normal physiological response, and it's not anything abnormal. It's not pathological. If you look at the longer acting esters like undecanoate, which are now finally becoming available in the United States, then it's actually much lower. It's like 7%. So that is an option. Topical treatment as well. It kind of depends on the concentration of the topical testosterone that you use, but you're looking at rates, they're quoting here at 12.8%, but that's with, the commercial androgel, which is pretty weak stuff. You could expect to see a higher rate with like the 20% compounded cream. But I'll tell you, I don't know exactly what the rate is. I couldn't find it documented for the 20% cream, but I anecdotally have had a number of guys who just had chronic hematocrit issues with intramuscular testosterone. Even when they switched over to the 20% topical cream, many of them had better hematocrits than they did when they were on the injectable. And I think it has to do with like there's a great deal of variability on your day-to-day levels when you use topical therapy, as opposed to sort of like generally more sustained, steady levels with injectable testosterone. It goes on here. The oral testosterone undecanoate has a very, very low rate. I mean, they're saying 0.003% of the patients studied on oral undecanoate have hematocrits greater than 52%. And then pellets are, they're not bad. It's about 1/3 of guys will get a bump in their hematocrit. So, clearly the most common delivery is intramuscular or subcutaneous injection, and that's the one that seems to cause the most problem, or the most grief, I guess, among patients and also among doctors that maybe don't understand the difference between primary and secondary erythrocytosis. We'll talk about that in a second. So, but the main fear that these guys have on the forums is getting some sort of a clot or some sort of a thromboembolic phenomenon. So, a DVT, deep venous thrombosis, a pulmonary embolism, which is where one of the clots, usually in the lower extremities, although you can get upper extremity clots in unusual circumstances, breaks off, goes to the lungs, and those are obviously really dangerous. They can absolutely be fatal. And then other things like like a stroke, that sort of thing. So what are the classic risk factors for stroke? So these are things that like I grill my medical students and residents on this all the time. I was grilled on it in med school. So there are some like very just sort of standard things that we know increase people's risk for stroke. And I like to divide them into two broad categories. One is acquired. So these are things that, throughout your life may happen to you that will raise your risk. And then there's inherited or hereditary clotting disorders, which are surprisingly common. I'm going to show you that in a second. So just real quick, this is not an exhaustive list, but in terms of acquired risk factors for DVT, obviously any kind of major surgery, especially like big orthopedic surgeries, hips, knees, that sort of thing, anything that causes you obviously to be bedridden for a prolonged period of time is going to increase your risk. Polytrauma. If you've had a prior clot in your legs, I mean, the valves in that vein, they're never the same again, and so your risk for another clot is increased just by virtue of having a clot in the past. Now, cancer is a huge one. In fact, sometimes clotting is one of the first manifestations that you have a malignancy. I've seen that on a number of occasions in the emergency room and chasing down clots. I find out that somebody's got a lung mass, and it turns out to be, small cell lung cancer. So not all cancers have the same amount of risk. Pancreatic, ovarian, stomach cancer, renal cancers, any adenocarcinoma, metastatic melanoma is pretty bad, lymphomas, those are all like super high risk. And anything that's metastatic, tends to be higher risk for clot, which kind of makes sense. You have more, I guess, higher tumor burden. Most people are aware of contraceptive pills, increasing your risk for DVT in women, especially if they smoke, especially if they're over the age of 35. Being obese, there's no shortage of that going around, right? That's an independent risk factor. That's something that you acquire in life, although I guess you could say a lot of people are born obese these days. COVID is definitely associated with disorders of clotting, as is the vaccine. I don't know if we can say that on this channel anymore, but that is a medical fact. So don't ban me, YouTube, for stating medical facts. And then now we got the hereditary ones. So this is kind of like this is the standard 5 that I will typically order if I'm going to do a hypercoagulable workup on somebody, which, believe it or not, I still do sometimes out of the emergency room if I think it's appropriate, especially if somebody's coming in with their second clot and it's a non-provoked clot, so they didn't have something happen to them, they don't have an obvious good reason to have a clot. I think it's worthwhile to check for these things. So factor V Leiden, prothrombin gene mutation, protein C, protein S deficiency, antithrombin 3 deficiency, those are kind of the basic ones. By no means is that an exhaustive list. Lipoprotein A probably should be thrown in there too. That is associated, they think, with increased risk of thrombosis. But this chart here is what I want to show you guys. This is kind of important to know. So this is just how common some of these are in the general population. So factor V Leiden being the most common one. It's actually in my family. General population, 3 to 7% walk around with factor V Leiden mutation, which puts them at increase for clotting. So, and then of all the people that come into the emergency room with their first blood clot, either in their legs or their lungs, 20% of them have factor V Leiden. So, and this is one of the issues that was with some of the rare studies that showed that there was an increased risk of clotting with patients who were on testosterone, is they didn't screen for these hereditary thrombophilias, and when they did, they realized there was no difference between the groups. So, spoiler alert: if you get a clot on testosterone, it's not the testosterone. It's very unlikely to be the testosterone, at least based on all of the evidence, which I'm going to review here in just a second. In fact, it's far more probable that you have one of these hereditary clotting disorders, or you had something else happen to you, some other risk factor for developing the clot. Okay, but I was actually surprised when I learned this a few years ago. 3 to 7% have factor V Leiden. You can see the other numbers there. They talk about hyperhomocystinemia, that is associated with clotting. and that's up to 5 to 10% of the population. So these are not uncommon. These are out there. So, okay, this is a paper here. I've reviewed this paper before, but it's a really good paper in a lot of different ways. It's from Hematologica 2019, and the title is Reevaluation of Hematocrit as a Determinant of Thrombotic Risk in Erythrocytosis. And there's a lot of there's some real gems in this article, but one of the main ones in there is they differentiate between primary and secondary erythrocytosis. So just briefly, primary is it's not caused by an external stimulus. It's not a response to something in the environment, like a low oxygen environment. It's a primary process. So the main one being polycythemia vera, which is a hematological malignancy. It's well known to be associated with thrombosis, but as they state very clearly in here, it's not so much the elevated hematocrit in polycythemia vera, but it's platelet dysfunction, and it may be disorders within the coagulation cascade that increase the risk of clotting. So people with polycythemia vera, they do benefit to some degree from phlebotomy to keep their hematocrit down. The interesting thing is when you normalize their hematocrit, you do lower their risk, but you don't lower it to the same degree as somebody who has the same hematocrit, for example, and doesn't have polycythemia vera. So again, it's something intrinsic to this blood-borne malignancy, polycythemia vera. And unfortunately, still in the medical world, doctors and patients to some extent, they conflate these two things as being the same. So the erythrocytosis, or the high hematocrit that you see in polycythemia vera, is associated with clotting, and therefore the high hematocrit that you see with testosterone must also be associated with clotting, and that's false. And this article talks all about that. So anyway, it's a really great article. I encourage you, if you really want to learn about the difference between primary and secondary erythrocytosis, this one really spells it out, and it's very clear in here. And this is a quote. It says, thrombotic events are well documented in patients with polycythemia vera, but not in patients with secondary erythrocytosis, such as cyanotic heart disorders, high altitude dwellers, testosterone therapy, obstructive sleep apnea, etc. So secondary is not associated with clotting. It's spelled out, clear as day in this article. So this article needs to be read by more physicians. Okay. Now, what about the risk of clotting just in general with, not so much related to hematocrit, but just with testosterone therapy? Because this is a constant myth. And it kept coming up on the forums, and guys who were going in for surgery. My doctor says I have to stop my testosterone, 2 weeks, 3 weeks, whatever it is, before my knee replacement. Or, I think one guy was going in to get a bunionectomy or something, which is not a major joint procedure associated with or high risk of thrombosis, in my opinion. I'm not a foot and ankle surgeon, but pretty sure that one's a low risk procedure. So, but the thought being that, we better stop this testosterone because you're going to get a major surgery and you're going to increase your risk of clot. And guys, I only picked a few studies here, but my goodness, there were dozens. If you go and you look in the literature, you can go back 30 years, and you can just find study after study after study showing no association between the treatment of hypogonadism with testosterone, whether it's topical or injectable, and an increased risk of thrombosis. There's just very, very little evidence to support that. You may find a few little studies here and there that show a risk, but again, many of those did not correct, and they did not screen out people that had these hereditary clotting disorders that I mentioned earlier, and they didn't clear out or screen out people with other risk factors for DVT, like smokers, for example. So, there are flaws in all studies, of course, but that was a major flaw. So if you look at the preponderance of evidence, it's just not there to support an increased clotting risk especially in an otherwise normal, healthy man who's being treated for low testosterone. Okay, so this is one here. This is from 2021 thrombosis research. It's a big meta-analysis, and And they looked over a whole series of studies. I'll cut to the chase on it because I want to go on to some of the other studies. Bottom line, here's a quote: TRT is not associated with an increase in VTE, venous thromboembolism, period. Okay. Next study here, this one is from the Journal of Urology. It is, from 2015. Association between use of exogenous testosterone therapy and risk of venous thrombotic events among exogenous testosterone treated and untreated men with hypogonadism. That's a long. Why did they pick such a long title? I mean, I can hardly get that out. Anyway, just yet another one. Okay, so this was like a really huge, like, retrospective study. So they gathered, they got 2,785 men who were on testosterone therapy being treated for hypogonadism, and then they had over 11,000 controls. So a pretty huge, like, group of patients to look at. Their conclusions, and I quote, "No significant association was found between testosterone therapy and incidence of idiopathic VTE, venous thromboembolism, as well as overall VTE in men with hypogonadism." Okay, big meta-analysis back in 2015, no association between thromboembolic disease, thrombosis, and treatment with TRT. Okay. All right. Yet another one, Journal of Urology. Like, these are, and by the way, these are not like little tiny journals that nobody reads, right? These are big journals. These are like well-known journals in the urology world. They're read by all urologists everywhere. Okay. So this one here from the Journal of Urology, it is medical treatments for hypogonadism do not significantly increase the risk of deep venous thrombosis over general population risk. See, I like it when a title just tells you exactly what the study's about, and that's what this one's all about. So in this one, they looked at 1,100, roughly 1,100 men. Yeah, it was 1,180 men with hypogonadism, and they were men actually. This one was good too because they looked at men who were being treated with clomiphene, as well as testosterone replacement, whether it's topical or injectable. So of the 1,180, 486 were being treated with Clomid. Okay, because I've heard some people say, well, maybe Clomid, there's a risk for clotting there too because of the zuclomiphene, etc. And so in this one, no added risk. Then they said here the majority of patients that did develop a DVT had other identifiable etiologies for the DVT. So at least in this study, they actually screened for other for risk factors for DVT. And then here's the kicker: polycythemia was not found to be a risk factor in the patients diagnosed with DVT. Okay, I'll say it again. Polycythemia was not found to be a risk factor in the patients diagnosed with DVTs. Okay, just for a little context with hematocrit, I like showing this paper because I think it puts things in perspective. All over the world, there are people that live at very, very, very high altitude, and they've been living there for thousands of years. Places like South America, obviously, and places like Nepal, people live, well above 10,000 feet, and they have built thriving civilizations there for thousands and thousands of years, and they have done just fine. So this is a paper from back in 2001, from the journal High Altitude Medicine and Biology. Normal hematologic values for healthy persons living at 4,000 meters in Bolivia. So, 10,000 feet-ish and above. Okay, so what is the average male hematocrit for just a sample population living above 4,000 meters in Bolivia? So average hematocrit, 52.7, average hemoglobin, 17.3. The range was somewhere between 45% and 61% for hematocrit and 13 to 21 for hemoglobin. So people walking around with hematocrits, so 50% of the population has a hematocrit above, we'll just say 53, so 52.7. So half of them are above 53. So, oh dear God, do we need to go down there and like start bleeding all these people? No, of course not. We don't. But if you're like one of these guys that I'm seeing on the forums, and they show up at their clinic one day, and they've got a hematocrit of 52.7, oh man, you better go down and donate some blood, man. You're going to get a stroke, you're going to get a heart attack, you're going to get PE, you're going to get a DVT, and this is just provably false. Okay, but I love this. It just puts the whole thing in perspective. It's entirely normal when you live at high altitude to have a significantly elevated hematocrit, and these people are not keeling over and dying of DVTs and PEs at a young age. It's just not happening. Okay. The take home. What are the take home messages here? So you do not need to just like routinely donate blood. There are some guys that are like, I donate blood every 2 months, no matter what. Okay, well, let me know how that works out for you like a year or two from now. When you feel terrible, you've crashed your ferritin, and maybe you have to go get IV iron infusions to replace all the iron that you've leached out of your bone marrow. That's just not indicated. Now listen, I fully recognize that there are some of you guys out there, and that when your hematocrit gets high, particularly if it gets 53, 54, 55. That you don't feel good. Some guys do feel like their heart is racing. They feel flushed. Maybe they've got a elevated blood pressure, that sort of thing. I'm not talking about those kind of cases, right? If you're symptomatic from an elevated hematocrit, then by all means, like maybe go donate some blood. But I will say though that that's not a long-term solution for your issue. If you have sustained hematocrit elevations that are symptomatic, it's a problem with your protocol. It's genetic. You've got a genetic predisposition. Maybe you've got an excessively sensitive androgen receptor. There could be a number of different things going on. But talk to your doctor about modifying your protocol. Maybe switching to topical therapy. Maybe going to, everyday, microdosing, etc. There's a lot of ways to tweak that. Maybe you need to lower your dose. I mean, that's an easy solution right there. But there are other options other than just like, phlebotomizing yourself all the way to, gross iron deficiency, because that's obviously not in your best interest. I just want to say it again, testosterone does not increase your risk of DVT in and of itself. If you get a DVT while you're on testosterone therapy, the odds are high, they're relatively high, that you have either a hereditary thrombophilia, one of the ones that I mentioned, or it's under you have a provoked DVT. You've had surgery. You've been immobilized. Maybe you're on a long airplane ride. I saw a guy in the emergency room just a week or two ago that took a long trip back from Europe and developed some calf and chest pain and was holding off and finally came in. And yeah, sure enough, he had multiple pulmonary emboli. So that's a risk factor, right? But if that guy was on testosterone therapy, I wouldn't have just knee-jerk said it's the testosterone. Absolutely not. But I know a lot of doctors probably would have that don't know any better. It was probably the combination of the long airplane ride, stasis, maybe some venous insufficiency, and maybe his factor V Leiden. 20% of people that show up with their first thrombosis event have factor V Leiden, according to the data. So anyway, just some other final take-home points. Obviously, follow your surgeon's advice, but you don't need to generally routinely, stop your TRT, X number of weeks prior to surgery. I'm not going to, step on your doctor's toes. If your doctor wants you to stop, you should stop. But there isn't any compelling reason for you to do it on your own unless you're specifically instructed to do so. In fact, if you're having a particularly big and bloody procedure, you may want to have a few extra red blood cells floating around just in case. Okay, maybe it would mean the difference between you needing a blood transfusion and not, and you should generally try to avoid blood transfusions if you can do it. And then finally, I just would reiterate: don't get your medical advice from a bunch of bros on Facebook TRT forums. Okay, there are guys on those forums that are super knowledgeable. But I hate to say it, they're drowned out 10 to 1 by guys who just are perpetuating these myths. They're not doctors. They have no medical training whatsoever. They're just repeating stuff that they either made up or that they was passed on to them on a Reddit forum. Or you don't know where they're getting their information. So if you have questions, if you have medical questions, ask a medical expert. preferably your personal doctor who's taking care of you, who knows you best, okay? Because that's where you'll get the answers. And I would encourage you to be your own advocate. People are like afraid to bother their doctors. It's your job to make sure that all of your questions are answered, but it's also your physician's job to make sure that they do a good job in answering all your questions. This is a two-way exchange. And so don't be afraid to advocate for yourself and ask lots of questions. Because if you leave your doctor's office with unanswered questions, and then you go to a Facebook forum, you're probably not going to get the best advice. Well, you get the advice that you pay for, I guess, which is, it's not going to be very good. So anyway, guys, that's all I have for you today. Maybe I'll touch on the SHBG thing, because that's been kind of eating at me a little bit. And then, the estrogen thing is a whole big can of worms that maybe I'll tackle that at a later time. But in the meantime, I hope you guys are well. Let me know what your experience has been with your hematocrit. Do you donate blood regularly? Do you not? Are you symptomatic? What I would really like to know is tell me what your clinic does. I'm really curious. I'd like to sample you guys. Let me know if there is one that you know of. What is the hematocrit threshold that your personal TRT physician says you have to go and donate blood? I would like to get a sample of that, just to kind of see what's out there. So, all right, guys, hope you're well. I will catch you next time. Bye. All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.